Welcome to The Backstory with Dr. Ricky Singh. This podcast is focused on bringing you the latest research-based information about dramatically improving health, well-being, and quality of life. And here's your host, Dr. Ricky Singh.
Welcome to The Backstory. Today we are speaking with an expert in cardiology, specifically heart health and specifically in women. And the purpose of the talk today was really to create awareness, to discuss the importance of talking about your heart health with your provider, whether it's your primary care doc or your cardiologist. Learn what are some of the risks in patients developing heart disease, and most importantly, what can you do to prevent it? What can you do to maintain a healthy heart? And if you are having a cardiac event, what are those symptoms like? So my guest today is the Associate Director for Consultative Cardiology and Director of the Women's Heart Program and Preventative Cardiology here at Weill Cornell Medicine, New York Presbyterian. So I'm really excited to have this talk, Dr. Nivi Amin. Dr. Amin, welcome to The Backstory.
Thank you so much. I'm really excited to be here.
So, tell me a little bit about you. Where were you brought up? How did you get interested in cardiology? And then how did you decide, I don't want to treat men. I want to focus on women's heart health. How'd you get interested in that?
So I grew up in Maryland, and actually I was really lucky to grow up very close to my grandparents. And I got interested in cardiology because it's been a part of my life since I was born. So the day after I was born, my grandfather survived a massive heart attack. He underwent several surgeries over the years, had multiple cardiac procedures, and had more than 30 happy, relatively healthy years as a result of what his cardiologists and cardiothoracic surgeons did for him. So I grew up in awe of what medicine could do for people, and specifically cardiology. I love cardiology because we can do all these really cool things for people, make them feel better if they're having chest pain, trouble breathing. But what's also great is that we can help people make changes in their lives to prevent heart disease. And that's where I think we can have the biggest impact in our patients' lives.
Let me ask you a philosophical question. And I know, when you go through medical school and even internal medicine residency, there's a group of people that say, I want to be a cardiologist. And rarely do they say, I want to be a cardiologist to prevent a bad outcome. They usually say, I want to be a cardiologist because I want to do stents. I want to do interventions. So how'd you kind of decide between kind of preventative cardiology and interventional cardiology?
That's a great question. I love it all. And at a certain point, I did want to be an interventional cardiologist. There's a true allure of being there right at the moment that somebody's having a heart attack and being able to open up those vessels. But the point is, we don't want our patients to get to that point. We want people to live happy, healthy lives and avoid those sorts of outcomes. And there's a huge field of preventive cardiology where we can identify people early before they start developing symptoms and put these patients on the right pathway before they develop disease. I also think that, as you know, healthy lifestyle, diet, exercise, this is the basis for good health overall. So as a cardiologist, I get to help people be healthy in their global life. And then if they have issues, can help guide them in the right direction to get the right treatment. So we really have the best of all worlds, where we have these longitudinal relationships with our patients, but can be with them for the emergency moments and take care of them afterwards.
Most people think that heart disease and heart attacks is a man's disease. You have high cholesterol, you have high blood pressure, you eat poorly, men get heart attack. But that's not really the truth. So what is the truth? What is this a risk for women? Are women at risk for suffering from heart disease?
Yes. So heart disease is the number one cause of death for women in the United States. And it's even a bigger problem than people realize. And so that's why it's really important. And I'm so grateful that you're doing this podcast to raise awareness. And that's part of my professional mission and personal mission, to raise awareness about women's heart disease.
You would think that women out there listening are worried about breast cancer or some type of obstetric or gynecological issue. But it's surprising to hear that heart disease is the number one killer of women in the United States. So that's why this is important. So how do we make this relevant? How do we get women out there to say, take care of your health, come see your doctor, get evaluated, learn the data? What's our next step?
I think it's really important to raise awareness. Women are getting routine screening with mammograms. They get a lot of screening for gynecologic health, like pap smears, and they have many different touch points for routine female sex-specific kinds of medical care. But alongside of that, we need to help women understand their own cardiac risk. One thing that I tell my patients, and I'd like all women to know, is that they need to know their numbers. This is something that they can get from their routine medical visits with all of those different touch points, their gynecologist, primary care doctor. So women need to know about what's their weight? Are they a healthy weight? What's their blood pressure? Are they at risk for developing hypertension or high blood pressure? What's their cholesterol? Do they have high blood glucose or blood sugar? So with this in mind, engaging their doctors in these conversations, women can then start opening the door and the pathway to more evaluation if it's needed. And all a woman needs to say is, doctor, I'd like to know my numbers. I'm concerned about my heart health, and I don't want to have a heart attack in the future.
I feel that most people, especially for cardiac, and I'm probably guilty of this, come in when they're feeling a certain way. Admittedly, I probably haven't gotten my blood pressure checked in 5 years.
We'll come across the street. We'll help you out.
There you go. I just turned 40 last summer, and at 40, I'm thinking, should I get some lab work? Check prostate, check my cholesterol, which I did do. So I'm on anti-cholesterol medication now. And women, for the most part, tend to be the healthcare decision makers in the family, right? They take care of their partners, their spouses, and their kids. But it sounds like they might be putting their own health in the rearview mirror. So how do we change that? How do we tell women, get your numbers, come see us? How do we motivate them to go out and seek that care?
Women, we need to take care of ourselves. We need to take time for ourselves. And you hit the nail on the head. So many women are balancing personal lives with their professional lives. Maybe they have children, they have aging family members, trying to make it through this chaotic, crazy world. It takes 5 minutes with your doctor. Just ask your doctor to have this information. With the information, you can empower yourself to then move forward with the right steps.
Is there a particular group of women that might be more at risk for developing heart disease? Should my wife, who's mid-30s, be concerned? Or is it my mother, who's in her 70s? Who's the biggest risk that you want to target?
The people that we want to target are the people before they have their heart disease. Of course, those are people who are younger but may have a family history of heart disease, or they may have some sex-specific risk factors such as pregnancy complications like high blood pressure, diabetes during pregnancy, or maybe premature menopause. Premature menopause can come about naturally, or it could be related to some other cancer therapies that they may have required. So those women are the ones who we want to target early and help modify risk factors. Now, the women who are at highest risk for having an event in the near future are those women who are postmenopausal, so they've completed menopause, and may have some of the traditional risk factors that we know of associated with heart disease, high blood pressure, diabetes, high cholesterol, family history, or maybe they're smoking. And we're seeing that the more weight we carry, so towards overweight and obesity, these can be independent risk factors as well.
What's actually happening in the body during postmenopause? Are there hormonal changes? What is actually happening that puts this group of patients at higher risk?
The thing that has protected women pre-menopause is estrogen. So estrogen is quite protective. And during menopause, through hormonal changes, women lose estrogen. And there are changes to physical changes that you can see from the outside. Women complain of metabolic changes that may lead to weight gain. There are then also vascular changes, so changes to the effect on blood vessels. So women may develop more high blood pressure. And going back to that metabolic change, women also may notice that the cholesterol starts creeping up without really changing diet or exercise very much. So it's really important to keep those in mind when going through changes.
When you evaluate a patient who's coming in relatively asymptomatic, maybe they don't even have a family history of a cardiac event, and you give them the numbers. You mentioned some of them earlier, like weight and blood pressure. What are some other tests that you might run on a patient that comes in? Blood work or heart testing and things like that?
Sure. So the most important test we can do is the conversation that we have with our patients. So really diving deep into their own personal history and really trying to tease out what happened during pregnancy, what age was a woman during menopause, what are some of those life stressors, so that we can understand where a woman's coming from at that moment. In addition to a physical exam, we'll do an EKG. An EKG is an electrocardiogram where we can look at the electricity passing through the heart, and it can tell us clues about the structure of the heart to see if there's something we need to look at more. Sometimes we refer patients for an ultrasound of the heart to look at the structure and function of the heart. We can also refer patients for non-invasive coronary calcium scoring, where we look to see if a patient has mature plaque, and that can help guide how aggressive to be with cholesterol management. Usually we're telling people start with diet and exercise, but by the time many people get to me, they're beyond that. They need a little bit more of an aggressive intervention, maybe because they have calcium in the arteries of the heart or they have a significant family history for heart disease. So there are a lot of different things we can do before getting to some of the more invasive or involved testing.
So, some of the testing sounds like you need to come to the physician and get that done, either blood work or, the calcium score that you mentioned. Nowadays at the Duane Reade or CVS, a lot of these places have those blood pressure cuffs that you can just use whenever you want. Would you recommend to our listeners out there, if they're 30, 40, 50-year-old women, go to your local pharmacy and just get your blood pressure checked and see what that number may look like?
I think that's a great idea. And people should definitely seek that information.
Are there cutoffs of blood pressure numbers that you would be alarmed and say, you know what, you should probably come in for a formal evaluation?
For our youngest patients, if they're continuing to have blood pressures consistently above 130 for the top number, which we call the systolic blood pressure, or well above 80, the bottom number, which is the diastolic blood pressure, that's a sign that at a young age, an individual is at risk for developing more severe high blood pressure, more severe hypertension.
It's tough to make preventative cardiology sexy or preventative physiatry, where I don't want to intervene. I actually want to give you the tools necessary to take care of your own health, eat right, exercise, etc. Sleep comes up a lot in the pain management world, and how that can relate to poor outcomes if you have poor sleep. Is there some data or some evidence to suggest the same in heart disease regarding sleep?
Absolutely. So people who aren't getting enough sleep are increasing the inflammation in their bodies. And inflammation is one of the key ingredients to developing plaque in the arteries of the heart. So plaque is a fatty substance that can then rupture and cause an acute heart attack, or can build up over time and reduce blood flow over time to the heart muscle. So that inflammation, together with other fats in the blood, especially cholesterol, can deposit and cause a problem. So how does low sleep or less sleep cause an increase in inflammation? It has to do with increased stress hormones from the sleeplessness. And with persistent circulating stress hormones, one's inflammation can increase. With the changes in circadian rhythm, we do affect the heart in different ways. And some of it is not as well known, but there's a lot of science out there really showing that ideally people should be getting like close to 7 hours of sleep a night, and doing too much less or even too much more can be problematic.
It's amazing. I've talked about spine health, and we had obesity management here, and now cardiology. Everyone talks about sleep and how important it is to get that restorative sleep to decrease what you're saying is inflammation. And stress also plays a role in inflammation within the body. We know that increased stress leads to poor outcomes for spine health. Increased stress leads to decreasing your basal metabolic rate, which can lead to weight gain. And you mentioned stress. How does stress play a role in increasing heart disease? Is it blood pressure, or is there actually something happening at the chemical level?
Stress increases one's risk for heart disease at multiple levels. It is incredibly problematic because at the chemical level, with the stress hormones, you can increase inflammation. With the stress response, the body's stress response, increasing blood pressure, the heart is working in overtime, the blood vessels respond. And what we're doing is we're activating our fight or flight response, which we all probably remember from high school biology. But having that when an animal is chasing you is okay. But having that persistently elevated, it can be really problematic for the heart.
No, I totally agree with you. We talk about stress as a beneficial tool in the body. Our bones need stress, our muscles need stress, but in small doses. When it becomes chronic, and then joints break down, inflammation throughout the body can cause a multitude of problems. Even neurologic issues like Alzheimer's can sometimes be caused by high inflammatory states. So you're the director of the Women's Heart Program here at Weill Cornell Medicine. Kind of talk us through what that initial evaluation is like. Is there a team of you working together to achieve the best outcomes? What is that experience like for the patient?
We really work together with the patient and their care team to understand their risk factors. And as I mentioned, do a thorough history and really get at some of the sex-specific risk factors, understanding where a woman is in her lifeline and also where she is at that moment in terms of stressors. The evaluation might involve referrals out to endocrinology or to other specialists within our institution, or it may also involve further counseling with nutrition services, coming up with an exercise plan with our patients, or other further diagnostic testing.
How important would you say is diet when it comes to maintaining good heart health?
Diet is up there, tied for first place with exercise and stress reduction.
What are the recommendations from the American Heart Association? How much should one individual be exercising on a regular basis?
The recommendations from the American Heart Association are very achievable. So to break it down, the American Heart Association recommends 150 minutes of moderate intensity exercise per week. So that could be 30 minutes, 5 days a week, or 75 minutes of intensive exercise over the course of a week. So what that means for people, moderate activity is walking at a brisk pace, a slow jog. It's a sort of activity where a person could have a conversation, but in short phrases. If you're able to sing while you're working out, you're not working out hard enough. And there actually is a curve of diminishing returns, basically, where people who are doing ultra vigorous exercise and almost too much of it, to get to your point of too much stress being a bad thing, there can be diminishing returns on too much high intensity exercise. But what I say to my patients is try to incorporate it into your day-to-day, make it a part of your routine, and try to get some vigorous activity as part of the routine exercise. So not just moderate level activity, but doing a little bit of interval training at times or other sorts of activities to rev up your heart a little bit more. I think that those are all very achievable.
What do you say to the patient who is interested in high-intensity interval training, but they might be afraid that, is my body ready for this? Should they get a consultation to just check their heart out to make sure they're ready, or is there other strategies?
I would certainly encourage an evaluation, and especially for people who have multiple risk factors for heart disease, who may not be doing routine exercise. I do see many people like that who just want to make sure their hearts are healthy enough to get even healthier. And for those people, we may do a stress test to test out the system.
So exercise 150 minutes a week of moderate intensity, like you mentioned. Going back to diet, probably during your thorough history and interview with the patient, you talk about, hey, what do you eat? What are your snacks like? What are some of the key things that stick out in patients where you immediately say you need to cut that out of your diet? What are some, especially in the Western diet, what are some things that you see a lot?
Cheese. So cheese has a lot of saturated fat, and women often turn to cheese as a source of calcium and protein, but we need to understand portion size.
My wife is not going to be happy that you said that.
I'm not happy with it either.
Cheese is a staple in our house. No meal goes without a little sprinkle of cheese on it. You mentioned...
May I interrupt you?
Go ahead.
So a little sprinkle of cheese is okay because it's probably within the serving size.
Fair enough. You mentioned calcium. Obviously bone health, especially in the musculoskeletal world, is very, very important to us. In postmenopausal women, we do see an increased risk of fractures and low bone mineral density. So at times, many are recommended to take calcium supplements, take vitamin D supplements for bone health. But some new data suggests that there might be a risk for a cardiac event in those taking calcium. What do you say to those patients, and how do you avoid that?
Yes, so calcium is really important for bone health. But what we recommend for our patients is that they get the majority of their calcium from naturally occurring sources like food, dairy, and of course, people who have cholesterol issues, I recommend low-fat dairy. But what we've seen is that people who over-supplement with calcium, the body has a tough time metabolizing that, and it can circulate looking for places to deposit, and some of that calcium can deposit where it's not supposed to be, like the blood vessels, and that can cause then further problems. But a woman who's taking a mix of supplements and dairy is probably okay. It's the individual who's taking excessive amounts of calcium.
Are there other patients who are more at risk of having low calcium based on their diet, like vegans, for example, or even vegetarians? Would those patients benefit from a supplement?
They may benefit from a supplement, but there is a lot of naturally occurring calcium in certain foods, like green leafy vegetables. But maybe those individuals would benefit from working with a nutritionist to make sure that they're getting a full balance of nutrients. Going back to diet, though, I will highlight the fact that we do recommend a mainly plant-based diet, sprinkling in occasional animal protein. So let's break that down. For most of our patients who are coming in, we're recommending lots of fruits, vegetables, whole grains. Carbohydrates are not bad for you. They just need to be complex carbohydrates. Nuts, healthy fats like from avocados and other dietary sources like fish. So we recommend having fish 2 to 3 times per week, especially the ones that have high omega-3 fatty acid levels, such as salmon. Sardines tend to have that too, but they can be quite salty. So people who have issues with high blood pressure, that may not be a good thing. But for women who are trying to boost their calcium, that may be okay because certain sardines still have a little bit of the bone in them. They can eat that.
Are there some fish that you may not recommend, bottom feeders or things that have high omega-6 versus high omega-3? What are some of those examples?
I don't get into too much of what I don't recommend in terms of the types of swimmy fish, but I do recommend that people who are watching their cholesterol stay away from shrimp or really, really reduce the amount of shrimp because that tends to be high cholesterol. So the bigger fish, such as salmon, they're eating a lot of phytonutrients out as part of their nutrition out in the open waters, and that's what gets converted into these healthy fats. So maybe looking for fish that are going to be a little bit more free swimming and having a little bit more of that natural environmental diet.
It's important this day and age, especially for people like you, people like me, to kind of lead by example. Our patients see us and they ask us, what do you eat? How do you exercise? How do you maintain health and wellness in your own body? So what are some of the things that you do? I know you're busy. You're a cardiologist at a big academic institution. What are some strategies that you implement in your own day-to-day routine to maintain a healthy outlook?
Yeah, so as you know, I'm balancing life with kids and a husband here in busy New York City, along with an academic cardiologist career. And what I've done is incorporate exercise in my daily commute. So I make sure that I walk to and from work, and I try to stay very active with my kids, going swimming, hiking, playing ball with them. And we stock our fridge with tons of healthy fruits and vegetables and healthy snacks, which I bring to work with me.
So diet and exercise, obviously tied for first in maintaining a healthy lifestyle. What about stress management? What are some tips that you can share with the listeners on reducing stress and anxiety and all the pressures of living in New York City?
Take a deep breath. So stress management is really one of the key factors of health, and also one of the most difficult things for patients and for us to try to reduce. So one of the recommendations that I have for my patients is to try to take a moment before bedtime to really just wind down. That's
kind of what we tell our daughter. We say lights are off, time to de-escalate.
Yeah.
Bring our heart rate down and our blood pressure to some extent, and I agree with you.
So I see that you have Dr. Parikh from the Integrative Health Center coming in to speak with you, and she has taught many of her patients, including me and my patients, about deep breathing and mindful breathing, and that really does help with stress reduction. I also just recommend that if possible, people have a really positive outlook and start a gratefulness practice. Some of these sorts of really small movements can help a patient mitigate stress. But as I said right at the beginning, one of the best ways is to just take a deep breath.
It's hearing you say this, it makes me think about how much crossover there is with spine and pain management with all the other specialties. We have all gotten so micro-specialized into what we do. We forget a lot of these tools work cross-discipline. Mindfulness, healthy eating, healthy sleep, stress reduction, and a lot of things have really, really positive outcomes in our patient population. Presumably you and I do our job to the best of our abilities. We educate the listeners out there on how to eat right, how to exercise, decrease the number of cardiac events that may occur in their life. What are you most excited about in the field of cardiology and looking for in the next 10 or 15 years?
I think that what we can do for patients in a minimally invasive way is phenomenal. We can detect disease well before it becomes symptomatic through a lot of our diagnostic testing. And if needed, people can have the equivalent of open heart surgery through catheters, through stents or valve replacements. But what I'm really excited about is identifying patients who are high risk for heart disease early. We're moving more towards precision medicine, genetic testing. We still have a lot to learn, but I'm really excited about that direction.
That's what excites me about my specialty, is that we still have a lot to learn, and that's why it never gets boring. We learn something new from every patient encounter. Anytime a patient tells us a symptom or an issue, sometimes we have to go research it, and that's what kind of motivates us to keep practicing the way we practice. So, Dr. Amin, thank you so much for spending time with us today on the backstory and educating us on some of the risk factors related to heart disease, specifically in women. But most importantly, it's about increasing awareness. And for those listeners out there, if you think you want to get an evaluation for your heart, even if you have no symptoms, now's the time to do it. Tomorrow is not guaranteed, and get the evaluation through heart testing, through lab testing. Check your blood pressure at your local pharmacy. Any closing remarks, Dr. Amin, for our listeners out there regarding heart health and the women's heart?
Well, first of all, thank you for inviting me. It's such an honor to be here. And I'll say, I agree with you that we need to raise awareness, and I'm really excited for what we can bring to our patients in the future. And I'll close by saying that in raising awareness, we are doing even more research in women, so we'll have more answers in the future for how to specifically prevent heart disease in women.
So all of you women listeners out there, as much as you take care of your families, your kids, your partners, the household, work, please find time to take care of your own health. Come to the Weill Cornell Women's Heart Program and seek that evaluation. On behalf of the Backstory, on behalf of my guest today, Dr. Nivi Amin, when it comes to your health, when it comes to your wellness, remember that we've got your back. Thank you.
Thank you.
Thanks for listening to The Backstory. Please subscribe, rate the podcast, and review The Backstory on Apple Podcast, Spotify, and Google Play Music. And feel free to share this podcast on social media or even your own website or blog. This podcast is for general information purposes only. It does not constitute the practice of medicine, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information is at the user's own risk. The content of this podcast is not intended to be a substitute for medical advice. To learn more about Dr. Singh and his clinical research, please follow him on social media. You can also sign up for his newsletter by going to www.rickysinghmd.com. That's RICKYSINGHMD.com.